At this point of the talk, I'll just present several cases to sink your teeth into, so to speak, as you enjoy your main course. Sometimes in the lab, long days, I'll think that this statement is possibly true. It's better that you don't understand EP. I like to listen to music during these ablations. I thought it was ironic that I saw this on Pandora at one point. Bruno Mars is a half Filipino brother also. These are all local cases, South Orange County patients. The first one being actually a sheriff's deputy. She was 44. She had complained of palpitations to her primary care doctor, tiredness, fatigue, some lightheadedness. And what was seen is that the patient actually had frequent runs of PVCs VT. This is an example of a strip from the Holter. So you can see this is definitely more than just an isolated phenomenon. She would actually have runs of ventricular tachycardia. Upon seeing the EKG, the primary care doctor promptly called the patient and said, "Get thee to the ER." But of course, as soon as she shows up to the hospital, this is her presenting EKG, and at the hospital they're thinking, what's the problem? The echocardiogram was done and it showed a normal ejection fraction. Stress test was performed, which was also normal. I pulled up the reading. It was read by one of our partner cardiologists, and it was an interesting observation. At 30 seconds, the test was stopped due to, at near peak exercise, what appeared to be a monomorphic as well as a polymorphic ventricular tachycardia. So if you look at the strip down here, of course you see the wide, bizarre complexes consistent with PVCs, and then sort of a blending. Initially you'd think this patient might be spiraling into torsade de pointe or a polymorphic VT, but really what's happening, the sinus sinus node conducted to the ventricle, and at the fast rate is actually blending at times, fusing with the actual PVC, giving it this polymorphic appearance. So sinus tachycardia fusion with ventricular tachycardia during the stress test. It's an interesting observation. But even at baseline at times she would have trigeminal PVCs. And this was actually an EKG seen 5 years ago. So even 5 years ago when she was complaining of palpitations, this same focus was the culprit. So there's a great amount of consistency, and I'll tell patients oftentimes, we'll tell patients when they have a focus that erupts that's this frequent, it is unlikely to go away. It can remain, granted, wax and wane at times in periods of life, but it never just disappears. A cardiac MRI was performed just to rule out the possibility of a structural heart disease. Steve mentioned ARVD, particularly as something that can present with these right ventricular tachycardias. It was negative, but the observation by our radiologist was keen. They noted normal interventricular septal contractility, but with mild dyskinesia, suspicious for an aberrant conduction pathway. And that was very, very nice, very astute to, exactly, I was surprised to look at that level of detail with the motion of the cardiac MRI. And if we think about how we actually activate our ventricles, it's from the atria through the AV node, bundle of His, and then dividing then into our bundle branches. Very, very high-speed conduction, specialized conduction tissue, which allows for simultaneous activation of the ventricles. Next slide. If you bring into now the activation pattern, discussion activation pattern of a left bundle branch block, for example, you activate through just the right bundle, the right ventricle, and everything else has to travel slowly. And I use the analogy of a country road, myocyte to myocyte, as compared to using the highly specialized conduction tissue. So you will see a late contraction of the lateral wall, particularly, which would result in this septal bulge or dyskinesia towards the right ventricle. So essentially what they were seeing, if you compare the left bundle branch block type PVC with the true left bundle branch, they look similar, and you can think about it this way, as Asim was saying before, the way you activate the ventricles is the same, whether you have a PVC or the left bundle, right? You'll have one side essentially activated versus the other, and that would explain the actual observation of the MRI reader, that there was dyskinesia or bulging of the septum. Just to bring into discussion again the outflow tract anatomy, the right ventricular outflow tract is anterior to the left ventricular outflow tract. which plays a part into the sort of presentation of these tachycardias on the 12 lead, as Asim mentioned earlier. Next slide. We mapped this patient, next slide, and found in the anterior aspect of the right ventricular outflow tract the earliest area of activation. So this was truly a right ventricular outflow tract ventricular tachycardia or PVC focus, well away from the His bundle, which is here seen in yellow. So a very safe location to ablate. And again, just showing the activation, earliest being red. And again, when we look at these electrograms, we're looking at the 12 lead, and particularly at the local signal, we want to see that we're very early. So earlier than what the surface EKG leads would see as the earliest eruption of a PVC. When we have a catheter inside the heart, we see at the local signal level we're well ahead. We're happy typically with 25 milliseconds, 30 milliseconds, we call pre-QRS, as a good site for ablation. Post-op day number 1, she did not have any PVCs. She was back to work in a week. Just to talk about the relationship between the actual burden and our patients and our results. This is a referral center in the Midwest, University of Michigan, for complex EP ablation procedures. They looked at 170 plus patients with PVCs referred. What's striking is that the average symptom duration was 5 years. So these patients actually were complaining of symptoms already for 5 years before they reached referral for a definitive therapy. 5 years to come back to our offices saying they had symptoms of palpitations before they get treatment. Just to remind ourselves of the reason why they keep coming back, right? Arterial blood pressure drops with each PVC. A PVC is really an empty contraction. It actually, the PVC occurs before the atria has time to contract and fill the ventricle. So essentially what comes out, or the output of the ventricle, is diminished. So this is just a single PVC, and you can see the arterial pulse pressure diminish to the point where oftentimes, nurses will be fooled to the point where we'll get patients referred for palpable bradycardia, essentially being caused by these PVCs, heart rates in the 30s or 40s, and then oftentimes I'll ask the nurse, well, what's going on with the rhythm? And lo and behold, we look at the rhythm strip, and actually they're having bigeminal or frequent PVCs resulting in that bradycardia. But you can see why these patients become lightheaded or dizzy, because their perfusion to the rest of the body is compromised. This study showed that, again, the 20 to 30% range is truly the danger zone, and they delineated that if you actually had a higher than 24% PVC burden, we all have about 100,000 heartbeats in a 24-hour period, so about a quarter of your beats being PVCs, you're more likely to have a depressed ejection fraction, whereas if you're under this cutoff, you're more likely to have a normalized ejection fraction. And what was nice to see is that once they achieved successful suppression with ablation, the ejection fractions did rise in follow-up. So case 2 is a nurse that works at Mission Hospital. She's 60, history of breast cancer, some history of PVCs, NSVT documented, with symptoms of fatigue, palpitations, and medicines were tried. Beta blockers were tried, flecainide was tried, but unfortunately did not relieve her symptoms. She had a normal echocardiogram next. These were her PVCs, so you can see she would sometimes be bigeminal pattern, sometimes in clusters, triplets, same focus, morphology next. And the total number of beats was not a lot. It was 5.2%, so what we would determine as moderate amount of PVCs. Typically we'll determine anything up to 5% is mild, moderate, 5 to 10%, heavy above 10%. Very heavy, definitely 15, 20 plus percent typically. Just to show again what the arterial pressure does with these clusters of PVCs. If a single PVC you thought looked bad, you can see again with these salvos of PVCs what happens to the drop in the arterial pressure. Right, this is what results in symptoms of lightheadedness, dizziness, fatigue. Again, just clusters of her PVCs. This was seen on a monitor even 3 years ago, or EKG 3 years ago. The same focus you can see, tall R waves, inferiorly consistent with an outflow tract type morphology. Thank you. This is her pre-ablation PVC. She was active that day. It was a good day to take her to the lab. And what you see here is this very early R wave in V1, this transition here. And when you have early R waves in V1, V2, that just tells you have a more posterior location, so the right ventricular outflow tract being closest to the chest, left ventricular outflow tract being behind. So that gives you that earlier R wave contribution in your V1 and V2 chest leads. And again, just highlighting the difference. Later transition with an RVOT PVC, you don't really have an R wave discernible to V3, as opposed to here you have already an R wave in V1, V2, more posterior LVOT versus RVOT. And you can see that we mapped it, the earliest ablation or earliest activation site was around, these are the coronary cusps right here. And right here, I'll show you, these are the takeoffs of the coronary arteries. So we have to delineate with a coronary angiogram. We ask our cardiology brethren to take backup call for us in case we need to shoot a coronary angiogram. They'll shoot it, and we have to delineate a 5 millimeter or greater ideal distance from the target. And here we're able to achieve that with a successful result. This is 1 week afterwards at the follow-up with no evidence of PVCs for this nurse of Mission Hospital. So we live by the water, and we have a very active elderly, I don't even want to use the word elderly, senior population in South Orange County. It's amazing to hear what people do with their retirement time. Sailing, hiking, marathoning. I feel lazy sometimes just hearing about what they do. This was a sailor that would like to go out on a boat by himself, and he felt like it wasn't safe anymore because at times he'd feel a loss of power to the point where he'd go to his knees on his deck. Fatigue, lightheadedness, so he really needed help with his symptoms, and if anything he felt that the beta blocker that was first line that was tried for him, attempted for him, actually worsened his symptoms. And if you think about it, it definitely can. If it doesn't really diminish the PVC frequency that much and only slows down the sinus node, you can imagine that arterial pulse pressure being delayed even further before it becomes meaningfully, perfusing, right, the brain. The PVC burden was heavy at 11.4%. This was his Holter monitor, bigeminal, and the EKG. And what's interesting about the EKG is that the pattern of activation and the what we call the R wave axis, the QRS axis, the way that the ventricle is activated, in other words, mirrors what happens in sinus rhythm. Right? The transition is very similar to sinus rhythm, to the point where you can imagine that this would be somewhere very close to his native conduction system on the septum. Right, so this is classic for what we call perihiscine type of focus, and even the width of the QRS is skinnier than what we've been seeing as well. Again, you can activate both ventricles more quickly if you're coming from the center. And what you see here is the His bundle. This is the septum, the interventricular septum, looking from the left ventricle towards the right ventricle. You can see the earliest area of activation mapping here, about 25 milliseconds or so pre-QRS. This was the location, and it was a safe distance from the His bundle where we ablated. So those are what we call perihiscine PVCs. Again, with the stability of the catheter, especially with remote navigation, you feel more secure because you have secure contact with the tissue as the heart moves to the point where it's not going to slip up, you're not going to lose conduction. And that question about how often do you lose AV conduction when you ablate, it really depends on the region. There's regions so remote from the AV conduction system that should never happen. Here obviously is a higher risk region. You have to be very careful. So the EKG post-ablation was clean, the AV conduction was preserved. He was back sailing a week later. So the final case is a retiree from New York City. He had seen multiple cardiologists in the past, had been treated for his palpitations, his PVCs, his VT with calcium channel blockers, multiple beta blockers. He was currently on Toprol XL. He actually did have chest discomfort with palpitations, which is not an uncommon complaint. That thud, that hollowness in the chest, discomfort, which we oftentimes think is just due to the PVCs, but you still have to do your due diligence next. Here we have runs of PVCs, VT, and then isolated, it's the same focus. Again, this transition, which is somewhat late across the precordium, but definitely an outflow tract type appearance. The event monitor also captured these in a bigeminal, trigeminal fashion, and this gentleman would definitely have runs of it. This is not a happy retirement for him yet. And again, more bigeminal type pattern next. Obviously, we look for structural reasons why to have ventricular arrhythmias. Stress tests are part of the workup. Angiograms are part of the workup. We had an ejection fraction here of 39%. I was already concerned that this burden of PVCs was starting to weaken him, to the point where I was worried that he might have coronary disease even. That has to be ruled out. So one of our partners did an angiogram. He actually found disease, 90% disease in the circumflex coronary artery. He received a stent, and the hope was, well, maybe this will help take care of the ventricular arrhythmia. But it was truly an idiopathic reason for having these PVCs. Here's the same focus, still having salvos, post PCI. And finally I did a Holter, again, not that we didn't know what the problem was, but we wanted to quantify what the problem was, and it was 31% PVC burden. So really incessant, very heavy burden PVCs. This guy was not in a good trajectory as far as his myocardium. Post PCI, this is the Holter next. There's a subtle difference that I wanted to highlight. Go back one other slide. This is PVC focus 1. This is the one that we've been focusing on. When we do a Holter also, we want to really look and discriminate the morphologies to see if some patients actually have not just 1, 2, sometimes 3 morphologies. We want to know going into whatever ablation procedure, we want to be able to target the dominant morphology. You can see that the skinniness, narrowness of this PVC compared to the wideness, the more slurred upstroke of this PVC, how wide it is. It oftentimes can suggest a more epicardial pattern of PVC. And again, it just shows, again, that wider type PVC compared to the narrower one that we saw. What's nice about these Holters, they can tell us. So the dominant PVC was the narrow one, had 30,000 beats. The wider one was almost 6,000 beats. So this was definitely the primary target and problem for this patient that we had to identify and take care of. Next, to the point where we mapped his PVC focus, and this is the the right ventricular outflow tract, left ventricular outflow tract. His location was actually between the cusp, between right and left coronary cusps. He did very well. I didn't actually go for the epicardial focus. At that time, it's a blend of sort of ablation, medical therapy to result in a good clinical outcome. He was actually a ballroom dancer, now I remember, and he was back to ballroom dancing about a week later. This just really talks about the QRS width, and when we look at PVCs, not all PVCs are created equal. We try to localize. But interestingly, if you have a wider PVC, you can actually have a higher risk of having a PVC-induced cardiomyopathy. And I guess the way to think about it, if you activate your ventricle more awkwardly, you can actually create more dysynchrony, and over time be more likely associated with a weakening of the heart compared to a narrow one. This just highlights our therapies, right? Of course, we always try first line, and the first line medicines, they do work somewhat. We can see 30–40% decreases in PVC burdens, right? Not cures, but improvement with treatment of beta blockers, right? And our antiarrhythmic drugs definitely do better from start to finish with therapy, right? But if you compare our class 1 and our class 3 antiarrhythmic drugs, right? Amiodarone, mexiletine, flecainide, propafenone, sotalol, of course you can see up to an 80% drop on average in PVC burden if you treat with these medications, better than our first line drugs, 30–40%. However, if you look at ablation, right, this is without medications, this definitely trumps medical therapy, and you don't have to take a drug. You don't have to worry about side effects, potentially even lethal, or with amiodarone, permanent side effects with medications to treat an ongoing problem. Of course, success rates vary by location. The outflow tracts we love to see because these are very safe places to ablate and with high success rates, 99% or greater. When we're dealing with thicker muscle tissue, such as the papillary muscle, our success rates go down, right? Non-outflow tract type locations. But the overall long-term success, either with or without a drug, is actually very, very good in treating these different locations of PVCs. Again, the papillary muscles here, we see a drop-off because the location can be embedded really in the muscle, and the ablation itself may not reach the focus as well as the thinner tissue, such as outflow tracts, for instance.
How long?
This one, I think, was about 5 years out for long-term. Yeah, 5 years out. And especially if you contrast it with the actual risk, right? People would think of, PVC, VT ablation as very risky. Well, it depends on the patient and the location, but these are typically very healthy individuals, especially with the idiopathic ones. And if you think of the access to get to the heart, this is not open heart surgery. A lot of the healing and recovery from open heart surgery morbidity is from the access. Here we're dealing with punctures that are smaller than the size of a pen that heal very well just with 12 minutes of holding pressure. To the point where the major complications at 2.4%, the majority of these described is actually just from access. And these are mitigated by more modern techniques. Ultrasound oftentimes will use to actually now see the structures to the point where we can avoid a lot of these types of complications. Right? AV block shouldn't happen ever now with modern mapping techniques, especially with remote navigation and stability. Right? So very safe procedure with incredibly high yield that gets people to be functional again without having to take a medication. It's really a win-win. Obviously, it takes a conversational level of trust with the patient and referring provider, but ultimately we think this is a better approach for a majority of patients that otherwise are being treated with medicines for long periods of time. So it brings to the point where we all know our patients that come to the office quite possibly better informed than we are about their disease process. They do their research. They already almost have an agenda oftentimes as far as what therapy they want. However, I have found this, that for PVCs, for some reason, a lot of what's known out there by patients is not easily or readily available for whatever reason. And maybe it's because PVC ablation is late to the game compared to SVT ablation or even AFib ablation. Maybe that's the reason why, if you look at the data, PVC and VT ablation is the #1 area of growth for EP programs, because it's just starting to flourish and people are starting to realize the benefit of these types of procedures, and now it's starting to disseminate. But I would ask you to help us inform our patients and your patients better to the point where they don't have to really try 1, 2, 3 drugs or take it for a year or two, or be necessarily dismissed as, well, your angiogram's normal, your stress test's normal, your echo's normal, this isn't going to kill you, it'll be okay, right? And then try an anti-anxiety drug on top of it. Well, why not consider a more curative approach to help them have a better quality of life?